Welcome to Conference Highlights, recorded in front of a live audience at an evidence-based perioperative medicine, that's EBPOM conference. EBPOM are world leaders in perioperative education, so why not join us at our next meeting with a special discount for Top Med Talk subscribers. Look us up on www.ebpom, that's EBPOM.com. Top Med Talk.
So it's a pleasure to welcome another friend and colleague from North Carolina across the pond. Dr. Padma Gulur is Vice Chair for Operation and Performance as of recently at Duke. She's a Professor of Anaesthesiology and a pain medicine specialist. And she's also quite new to Twitter. So if you look up Dr. D-O-C-T-O-R Gulur, she needs some followers, if that's all right.
Thank you very much, Mike. Thank you for the Twitter introduction. Does choice of opioids influence outcomes? Just to ask the room over here, how many people here treat pain? If we're practicing, we're treating pain for the most part. And the question that we wanted to ask ourselves, I have no disclosures, by the way, is, are we doing the best we can? Is there something more we could be doing to make that outcome better? A gripping issue for us in the United States is the prescription opioid epidemic. For many who are not in the United States, it may seem distant, but we're going to talk a little bit about how we got there. I'd like to talk a little bit about whether opioids influence outcomes as a patient outcomes overall, and can the choice of opioids, so that you hear a lot of conversation about should you do opioids or not do opioids. But if we believe that, opioids have some role to play, can the choice of what you're using make a difference? And what are the implications in clinical practice if they do, right? So the prescription opioid epidemic, the United States, unfortunately, is in the midst of it. How did we get there? One statistic, 1 death every 24 minutes. It would be completely unacceptable for anything that we do, that we prescribe, to create this kind of an outcome. And yet that's where we are in the United States today. You heard Saul yesterday talk about motor vehicle accidents. Used to be the number one cause of accidental death in the United States in 2007 and 2008. Prescription drugs overtook that as the number one cause of accidental death in the United States. And this is affecting children, adolescents, elderly, just about everybody. So how did we get there? The U.S., we make up about 4.6% of the world's population. However, we consume about 81% of the world's production of oxycodone. That seems disproportionately high. When I give this talk in the United States, the question I ask my colleagues over there are, is it just that we're treating pain way better and the rest of the world is hurting? Or is it that we're using this medication way more than it needs to be because other people are able to manage pain without using it to this extent? We have about almost 2 million Americans that we know of who are addicted to these medications. And 4 out of 5 using illicit drugs like heroin, you can track them back. It started with prescription opioids, actually. So we wanted to see, we know that these opioids are causing this large social catastrophe in our country, but what about patient outcomes itself? Like, how are they influencing those? And so we looked at some, outcomes of interest. This is Duke data, and what you're seeing on the left is a live dashboard that we have where we track this now on an ongoing basis and have for the last few years, where we see how patients who are on opioids at the time of admission, so these are patients who are already on opioids for other reasons when they come in for another hospitalization or surgery, compared to patients who are not. And actually, the real difference here is that we actually put a cutoff of 60 milligrams. They have to be on 60 milligrams of oral morphine equivalents for at least 7 days to be considered tolerant, and we compared those patients to the general population. At Duke, we have 1 in 12 patients who are already on chronic opioids at large doses when they come into the hospital for admission. And when we looked at their outcomes in terms of readmissions, which is by and far one of the costliest aspects of care for us, is when a patient goes out, gets discharged home, doesn't do well, and has to come back in and get readmitted, we see an increased number of readmissions, actually significantly increased, almost to the point where, it's 10% for our regular population, 17% for the opioid populations at 30 days. If you push this out to 90 days, it's actually 45 to 50%. So 1 in 2 patients who are admitted on opioids are likely to come back into the hospital within 90 days after a discharge. The emergency room visits, no surprises there, are increased. Adverse events are increased. You'd think the tolerance would give them, an edge on side effects or other issues. And in fact, this population has more adverse events related to these medications than the general population. And no surprises, patient satisfaction. Are they feeling better about things? No. We, capture our patient satisfaction rates using HCAP scores. And our HCAP scores are 20 points lower for this population compared to the rest. Okay, so they're unhappy and they're not doing as well. So how is this from an international perspective? Since the United States, I just gave you the information, 80% of one of the most potent opioids we use the most of. How's it going for the rest of the world? Well, as you can look up there, we're actually not number one when you look at opioids consumed per capita. Canada has actually overtaken us to some extent. The United Kingdom is still not up there, but if you looked at this graph, which, by the way, is easily available, it's the International Narcotic Control Board, and it's a live graph that you can see in. Unfortunately, it's a few years delayed, so 2015 is the last data you can see right now. But you can see that the United Kingdom actually has started to show increased use compared to a few years before. And that's what you're seeing on the right side. You know, there's a concerning trend. It's still nowhere near where we are in the United States, but the deaths here seem to be increasing, and I think Natasha is going to follow, is going to talk about that a little bit more. So how do you influence these outcomes? Obviously, opioids do influence them. And the second question that we ask ourselves is, what about the choice of opioid? Could that make a difference? So here, what I'm showing you now for the next few slides is a study we did at Mass General Hospital where I used to work before. And what we found was, this is back comparing a period from 2006 to 2013, we saw that we were using opioids at a 5-fold greater amount. We were prescribing 5-fold more opioids to the same number of patients with the same acuity. And what we found was that hydromorphone use. What is the primary? How many people here use morphine as the primary intravenous opioid? If I was to ask this question in the United States, you wouldn't see a hand up. You would see hydromorphone is the number one. So we as a nation moved towards hydromorphone use intravenous. And I'll just point out there, this was driven by anesthesiologists, in the United States. Not well known, not much spoken of, but when we went back to see how did we do this, how did the MGH move from giving morphine as first-line agent to hydromorphone at this rapid rate, we tracked it back and we asked the internists and others who were prescribing this on the floors, and we said, why are you using hydromorphone? Why choose that? Oh, they come out of the recovery room on hydromorphone. So that's why we've been prescribing it. When we checked in the recovery room, why are you doing that? Well, because in the OR they used hydromorphone. And it's going to sound really silly, but when we asked why in the OR were we using hydromorphone and not morphine, it was because of the size of the vial. So what happened was that we were asked to hold on to these medications, where before we would just have a bag of medications, these controlled substances, they would just hang out. We started to have to carry them with us if we left. They had to stay with us. And so that bag had to get small and get fit into our pocket. And morphine, we need to carry a bunch of vials. And the more potent drug, you can just carry one vial. And so the pharmacy started substituting hydromorphone into those kits. And that's how it started. I know it sounds ridiculous. How can you drive this based on the size of the bag and the fact, talk about unintended consequence, but that's what we found. And you can see over here in our graph, our hydromorphone use was just out of control and morphine started dropping completely in the way we were using it. Well, that's okay. Did things get better? Well, when we looked at our patient satisfaction scores, and that's the line you're seeing, here it is, a 5-fold increase in opioids that we're prescribing to these patients. Are patients happier because we're controlling their pain better? And the answer was no. Our reported patient satisfaction didn't budge. Patients felt we were treating pain just about the same, and yet we were prescribing 5 times the amount of opioid we were in 2006. Our adverse events, no surprises, we're using a lot more. We started to have more adverse events, with this. Increased costs. Hydromorphone is more expensive. It's not a huge amount for the United States, compared to one chemotherapeutic drug. Sometimes it's the budget that an entire hospital uses for opioids. So that's the other problem. The opioids are really, really cheap. And therefore, it's not something that people focus on too much, or you don't get too much control on what you're using with that. But also the indirect, because of the adverse effects that we were facing. We had increased lengths of stay and readmissions for patients treated with hydromorphone, we found. Now we were concerned. We said, how did this happen? And is this just happening in Mass General? Why hydromorphone over morphine? When we started asking providers a little bit more about why they were sticking to it and why they wouldn't use morphine as much, is it better analgesia? When you review the evidence, there's a Cochrane review, one from 2002, another one from 2009. No, the analgesia is not better, because in the end it's about equianalgesia. You use the right dose, you can get people comfortable. Less side effects, maybe that's the reason, because you hear a lot about histamine release. You hear about, in medical school they told me that don't use morphine because it has active metabolites. Well, guess what? Yes, it does. Morphine 6 and morphine 3. Does hydromorphone not have an active metabolite? It doesn't have the 6, but it has the 3. And if you use it for long enough, and yet you'd be surprised at how many people don't recognize that. They think in renal failure it's a great drug to use, is what a lot of people will tell me. So side effects are not better, analgesia is not better. Why are we still using it? When we ask some of our PACU nurses, for instance, what prompts you, what makes you do this? The patients like it. The patients are happy. And that's a good thing. That's a great thing. I mean, we want our patients satisfied. In fact, a lot of my reimbursement is linked to the fact that my patients are satisfied. Yet I just showed you that satisfaction didn't really improve overall. But it is a likable, reinforcing drug. It gives you a lot of positive reinforcements. Patients who are treated with hydromorphone, and I can give you that experience from the U.S., very hard to get them off of intravenous hydromorphone. Patients really like the feeling on intravenous hydromorphone. Try converting that to oral hydromorphone, not good enough. Oral anything else, forget it. Okay, it's not going to happen easily because patients really like that feeling. Okay, in fact, on the street in the United States, this is called hospital heroin. So prescription drug abuse epidemic, we just talked about the street. I just love looking at this slide. You look at the first graph over here. This is the street price for these prescription drugs, right? Morphine, you can get it at 50 cents. Hydromorphone, $4. See the potency? See the conversions? They're fantastic. They're absolutely fantastic. They actually, the market dynamics work really well for this. This is easily available and they charge appropriately for it. However, it's causing increase in ED visits. It's causing a lot of increase for us, about a 422% increase in ED visits since hydromorphone started becoming the drug of choice in hospitals. Higher mortality. So when you actually look at the number, oxycodone is still the highest oral prescription at discharge for us, though hydromorphone is quickly taking that over. But this is slightly older, and I'll tell you why that data is older. The United States funding went away, and we don't monitor that anymore, and that's why I couldn't give you anything more recent. But there were 1,272 oxycodone deaths, only 132 hydromorphone deaths when we looked at this in 2013. Look at the deaths per 100,000 prescriptions, almost a 4-fold increase with hydromorphone compared to oxycodone. And that's where this starts to get concerning. So we looked at other hospitals. We said, is this an MGH issue? Is it just us? How's it looking the rest of the place? The University Healthcare UHC database is a large database based for university hospitals, large academic centers. And from 2010 to 2012, we looked at hospitals that had greater than 500 beds, academic centers, so similar hospitals. And we looked at them and we classified them as hospitals that primarily used a lot of hydromorphone, because every hospital uses both. But hospitals that had shifted more to using hydromorphone and hospitals that had not. And what we found is overall, if you look at the amount of opioid used, hydromorphone hospitals, as a rule, just like we found at MGH, were using more opioid than the other hospitals were. And now remember, these are similar hospitals and should technically, when you looked at how we compared them, use about the same because they're treating about the same kind of things. We then looked at some other outcomes, readmission rates, worse for hospitals that were using hydromorphone primarily, whereas if you looked at adverse events, which was rescue use of naloxone, this is something that's measured and reported for us as well. Morphine hospitals that use morphine primarily, use Narcan at about 1.5% or lower. The hydromorphone hospitals were using it at 3%. So obviously there's some kind of an effect here that we needed to give some further attention to. And patient satisfaction, pretty happy, the morphine hospital patients. Hydromorphone hospitals didn't start out happy, but eventually got to a better score. So actually, even from a patient satisfaction perspective, we really didn't have the problems with morphine that we thought. What did we do with this information? At MGH, we actually started to try to move more towards morphine first. That was the initiative. It should be called morphine first, which is offer morphine first and only go to hydromorphone if not necessary. We have a 6-month pre-post on this, and what we found was our overall opioid prescription went down when we moved to morphine first. And our patient satisfaction, actually, surprisingly, that line that didn't budge, for the first 6 months did better. We actually had more satisfaction rates once we moved to that. So how do you take this information? How do you do it in a clinical care model? Is it just that we switch from hydromorphone to morphine? What about fentanyl? What are the other choices? How do you actually incorporate this information and make a difference for pain management? Well, here's some of the experiences that I'd like to share with you. Here at Duke, other live dashboard, one of the other things we monitor is how many patients come in on opioids, yes, but how many of them leave on opioids and how much are they leaving on? And the color of interest here for us is orange, which means they came in on naive. They came in on less than 60 milligrams of oral morphine equivalents, but left on greater than 60 of oral morphine equivalents. No surprises there. The 4 highest diagnoses that this happened for, 3 of them are surgical, right? That's when we were prescribing these larger amounts. And the top one was actually joint surgery. They sent home 72% of their patients did not come in on high-dose opioids, but off they went on large doses. This one that was a surprise for us, spine fusions was the second one, no surprises there, was cesarean sections. We were sending our patients who had cesarean sections out, 50% of them almost left on high-dose opioids. And that completely surprised us. What happened over here? The fourth population for us is sickle cell. We treat that in large amounts. So C-sections, we found out, was because of templates, and the standardization. It's awesome, but you also have people who are just clicking buttons and sending everybody out on the same prescription. And that led to the persistent postoperative use of opioids, which is the graph on the side that you're seeing. And what we found is that almost 10% of patients who were sent out on this amount of medication, because one of the arguments I got initially when we looked at this was, well, that's okay. We're just prescribing it for the first month. They'll wean down and they won't have any other effect. But when we followed them out for up to a year, we found that there was at least 10% of these patients were using these opioids even at 1 year out, from the procedure per se. So, obviously it's worth doing something. We did a study with these patients and we said, all right, if this is what's causing this issue, the standard prescriptions, what are the patients actually using? And can we get more personalized about these prescriptions? We've done this for urology. We've done it for thoracic surgery, neurosurgery, and the C-section population, the OBGYN population, because those were of interest to us. And what we found is that overall, patients across these things actually used on average 30% of the prescription we were sending out. So we were really prescribing a lot more. What prompted that? We were treating the tail. So the majority of patients don't need it, but a few patients needed it. And those few patients would call these practices so much that it just became easier to raise that amount standard and start sending everybody out on 30 pills. So because you were trying to reduce the number of callbacks. Done with good intention. A lot of people critique that and say that as do not call me medicine. It's physicians not wanting to get bothered afterwards. But it's really more they were trying to address the patient's needs. And they felt like, the few patients who were calling back, that maybe the needs were higher, right? But with this survey, the other issue was, of course, what were they doing with the extra medication? Because we said, if you have that much extra, what were you doing? Most of them retained it. And this has led in the United States to a significant amount of our problems, right? All this excess medication sitting in bathroom cabinets, unlocked, not stored, no take back, no education on storage and disposal. And we're starting to do that now, and it's making a huge difference. Because I can tell you that for the first time, I've shown you a lot of data that's going the other way, but I can share with you that until 2016, our production of opioids in the country was logarithmically increasing. And for 2017 and 18, with this education, with this awareness, for the first time, the quotas have gone down to 2012 levels, actually. So this does work. All of this, effort has actually paid off. And what we've been able to do is reduce the amount that we're prescribing for some of these surgeries, and we intend to continue, work with other surgical services to figure out what would be a more ideal amount if patients are being sent out on it. We've seen the results of it, for orthopedic surgery. Already the numbers have gone down. They used to send down 72% of their patients went. It's down to 56%. This is information, by the way, in 2 months, 2 to 3 months. We expect this to be even better over time. And the cesarean section population has gone down by half already and will likely go even lower. So we've seen the results. We're looking also at our med harm rates, and we find that those have reduced significantly, and our patient satisfaction is about the same. In fact, for our chronic opioid populations improved from 50 to 60% of those patients. So we're doing something right with this approach. Taking this, little initiative, we said we need to apply this to a broader scale. We really need to support these patients because it's not all about opioids. It's also about optimal pain management. It's not about taking these drugs away, but it's about ensuring that they have great pain control without needing to rely on these medications. So we started this perioperative pain clinic at Duke. It's one of the first in our country. And what we do is we see the patients from decision to surgery. So it's up to the surgeon. As soon as they decide, they can send the patient to us if they think, and I'll show you the criteria, that the patient needs additional help because they're likely to have poor pain outcomes. And that, on average, could be 30 days for us right now and sometimes up to 2 months, 2 to 3 months. We follow the patients through the inpatient period, after the optimization period, and we support them for 90 days after surgery. We actually follow them through the subacute phase and give them some a gentler hand back in the community is our approach with that. It is multimodal. We have nutrition experts in all the great work that Paul just spoke about. It's not just perioperative. Nutrition makes a huge difference from a pain perspective as well. We have pain psychologists to help with the behavioral components, and we have physical therapists and prehabilitation strategies to try to help. We also implemented pharmacogenetic testing to personalize our approach in taking care of these patients, and this is where the choice of opioid makes a big difference. The other thing we do is for those patients that have difficulty coming off, we get them off the higher potency, higher reinforcing drugs onto the lower reinforcing drugs. And with that, we found that postoperatively we are able to manage them better. Who do we optimize? Anybody with pain, anybody who has substance use, chronic opioid use, but also look on the right side. People with depression, anxiety, personality disorders, catastrophizers, pain catastrophizing scale. How many people here have heard of or used the pain catastrophizing scale. It's awesome. So I'm going to say one of the scales that makes such an impact, such an absolute impact. If I see that catastrophizing scale before I go into the room, I have a sense of what to expect. I know what we're going to be dealing with. So perioperative pain management, what is our strategy? We have once those aspects occur and the patient comes to our clinic, we actually screen them more deliberately to look for risk factors. We optimize psychologically, medically, and physically before we send them in. And you can see all the components, the nutrition, the prehab, but also opioid weaning. So we have a very strict multimodal approach to this. We talk to them about weaning their opioids before surgery. What a concept. Why would we do that? Right? I don't want them in pain before. That's true. We want to use other modalities to help them with their pain, try to get them down on the opioids. There's plenty of studies now in spine surgery, joints, and abdominal surgery that if you can bring them down off their opioids, 50% reduction, you improve their outcomes immensely. Okay, the outcomes we spoke about before. So patients ask me all the time, better than opioids? Patients are not the only one. Our referring providers ask, because a lot of us actually believe that opioids are truly the only things that can help us, at least in the United States, help manage pain. And the answer is you've got a Cochrane review that shows you that when they actually compared these medications, ibuprofen, acetaminophen do just as well, or better, actually, than giving a patient 2 Percocets or 2 oxycodone. So we do use this information and this evidence to start informing practice, educate our patients on it as well. We have created this 9 things to talk to your patients about regarding long-term opioid use. And you're asking why? Why do we need this? We need this because the med safety, the side effects of opioids that is there in the label is far inadequate to educate our patients on what long-term use of these medications can do. So we talk to them about the GI issues that they can have on this, right? Especially after surgery. Slows the gut. Is that really what we want? Infection risk is increased. You've got data that wound healing is impaired. Sleep-related breathing problems that they can develop. Cardiovascular issues. Hyperalgesia. The fact that they're increasing the medications, many times patients tell you, I've taken more and more and I need it because my pain's not getting any better. Well, it may be that you are actually hyperalgesic. You're actually in more pain because of these medications. They have an increased risk of fractures, hormone problems. I cannot tell you how many patients on chronic opioids show up and have had a lot of workup for testosterone levels, because the part that's completely forgotten is they're on high-dose opioids. That's what's driving this. Depression. There's a lot of these patients who are actually depressed, and we need to talk about the fact that long-term opioid use can sometimes promote that. So we've been taking care of about, as I said, over a year with this clinic. We've had about 600 patients go through it. And we did a propensity match control to see, are we doing better? Because one of the things we absolutely want to do as we do these newer interventions which are added is to follow our outcomes and see if we're actually making a difference, otherwise tweak them. And so one of our goals was opioid reduction. Can we do that? You can see over here that on average, in the first bar is what they presented to us with. On average, our patients were on over 200 oral morphine equivalents. We did about a 13.5 dose reduction, so we tried weaning, but we weren't successful with everyone. It's a newer clinic. We have been more and more successful with the later patients. And on average, these patients showed up about 30 days before surgery. But the metric at discharge, as you can see, they shoot up. They use a lot more medication at discharge. However, the part that was most interesting is the control population, they use 20% more than that baseline, more than that first visit at 90 days post-surgery. That's pretty much our control, our standard. Patients who had been seen in this clinic had a 30% reduction in the amount of medication they were using compared to what they were using pre-surgery. So we made a huge difference with that, and that really has helped drive some of our other outcomes, which is the 30-day readmission rates and 30-day ED visits. You're seeing some of the early data here. We actually have the rest of the analysis almost complete, and we're continuing to see this. So this one is not statistically significant, though you can see the trend, but we're actually starting to see that with our second analysis now that we have more patients in the mix. So we think this is obviously making a huge difference. We're able to optimize our perioperative patients better. We decided that this needs to move to a larger scale because it's not just perioperative. And we're pushing now for integrated pain management, which Saul alluded to in his talk yesterday. And our approach over there is that we want to screen all patients who present to the health system for any reason. It could be an ingrown toenail all the way to surgery. We want to know, are they at risk for poor pain outcomes? So just as you have an allergy button, what we're going to create is we're going to put in 2 screening questions. And what those 2 screening questions will do is identify if the patient is part of the 80%, the green as we say, who do just fine in our healthcare system and we need nothing different for them. Are you green or are you not green? That's all those two questions will do. If you are not green, then you will get the additional level of screening and support from our specialized services. And our intent over here is, by the way, in that 20% that's likely to need this help, you're going to have 1 or 2% who are really, there's not much we can change in their trajectory, unfortunately, because of the chronic use and the high doses. But for about 15 to 18% of them, they have modifiable risk factors, and our hope is to have them followed in the specialized clinic so we can modify those risk factors and get them back to becoming green. Instead of what usually happens right now is that 15 to 18% become our high resource utilizers as they go through the health system. And how do you do that? Right from the beginning, we have genetic testing, screening, et cetera, optimization, and management. And this is our care pathway. I won't go through it in full detail, but as you can see, we have a pretty comprehensive approach to taking care of these patients once they're screened and followed through. And we are currently conducting our pilot phase with 2 large clinics that are going to take care of patients this way. I'd like to end by just thanking some of our collaborators. So we have a research collaboration with MIT, our health economists, Joe Doyle and Murray Jacobson from the UCI Paul Marat School of Business. Tasha from UCL has been kind enough to join us as well in this effort. And we have multiple things. We have randomized controlled trials. We're studying the pathways that we have put in place. And you might ask, why are we seeking international collaboration? Because obviously the way we do things in the U.S. is different, and we'd like to see how things are done elsewhere and how they compare overall. And I put in a question mark because if there's anyone else who's interested in joining us in this effort, we would more than welcome that. So in summary, choice of opioids influences outcomes. There's no doubt about that. And optimal pain management is more than just choice of drugs. It influences population health. And it is my sincere hope that, there'll be more attention paid to this. Thank you.
Nick Jerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.